We're indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us on today. Now, allow me a moment to introduce our platform, ClearNet. It stands as one of the largest live digital semi platform in India, providing a space for doctors to create and share their medical content. So, for today, we have with us our esteemed academic chairperson, Dr.A.L.Meenakshi Sundaram sir, who has completed MBBS, DA, MD. He is a distinguished anesthesiologist and medical administrator with a remarkable career in both clinical practice and academic leadership, serving as the administrator in government medical colleges across Theni, Chennai, Thanjavur, and Tirunelveli. Sir has played a pivotal role in shaping medical education. As a professor of anesthesiology, he has mentored countless medical professionals, contributing significantly to the advancement of anesthetic sciences. His leadership extends to national and state level professionals organizations, having served as the national vice president of the Indian Society of Anesthesiologists 2016 and a National Governing Council member from 2009 to 12. Additionally, his tenure as president from 2011 to 12 and state secretary from 2006 to 2010 of the ISA Tamil Nadu state branch reflects his unwavering commitment to the growth and development of anesthesiology in India. So for today, we will be engaging on a discussion on coronary stent anesthetic implications. So without any further ado, sir, I would like to hand over the session to you for the further proceeding. Over to you, sir. Please proceed with your talk.
Thank you, ClearNet, for the wonderful connectivity and partnering the eminent scientific session. Now I request Dr. Munian, President, ISA Puthukkottai City Branch, to offer his presidential address.
Sir, good evening, sir. It's my honor to welcome you to the online webinar conducted by ISA Puthukkottai City Branch in the name of Puthukkottai Bhudan. Today is the 6th episode of our online webinar. Our association represents the collective voice of our specialty, dedicated to promoting the highest standard of anesthesia care, education, like our online webinar and research. As anesthesiologists, we play a vital role in ensuring the safety and well-being of our patients during surgery and anesthesia and other medical procedures. Last week, we conducted a webinar on the mechanical ventilation by Lady Wadi Medical College, which was attended by 928 delegates. Every week, our delegates are increasing. Great thanks to my professor and our academic chairman, Dr. A.L. sir. In our webinar, PG students are actively participating in our webinar. Our webinar reaching national as well as international level. Today, our webinars on coronary stent and anesthetic implications. Dr.Vignesh, PG student, Andhra Medical College, Vizag. He will talk on the physiology of coronary circulations. And welcome, sir. And Dr.S.Rajasekaran, HOD retired, Department of Anesthesiology, Majardah Hospital, General Hospital in Saudi Arabia. He will talk on the topic of coronary stent. Welcome, sir. And anesthetic management of coronary stent for non-cardiac surgery by Dr. Sateesh Kumar, Associate Professor, Andhra Medical College, Vizag. Welcome, sir. The whole session will be moderated by Dr. Vijish Venugopal, Principal, KMCT Medical College, Calicut, Kerala. Coronary stent and anesthesia implication would likely emphasize the importance of careful perioperative management on patients with the coronary stent. This may include considering the timing of surgery or the stent placement, the use of antiplatelet therapy, and the patient's risk of bleeding and stent thrombosis. Key considerations: timing of surgery may be delayed for any bare metal stent 4 to 6 weeks, and drug-eluting stent may delay for 6 to 12 months. For and the antiplatelet therapy, continue the aspirin and clopidogrel as prescribed by the cardiologist, but consider the withholding of drugs 5 to 7 days if necessary. I think, but may continue aspirin for small surgery like cataract. And the potential risk of, we have to anticipate the potential risk of bleeding complication. We have to develop a strategy to minimize the complications if occurring. The anesthetic implications are Perioperative assessment, careful evaluation of the patient by medical history, physical conditions, laboratory investigation to determine the best anesthetic approach. Intraoperative management, we have to continuous monitoring the patient's ECG, blood pressure, saturation, and should be prepared to manage the potential complications occurring. Post-operative care, closely monitor the patients for signs of any bleeding, stent thrombosis, and adjust the antiplatelet therapy as needed. Overall, our aim is to raise the awareness about the importance of careful perioperative management and promote the best practice in our anesthesia care. Patients with coronary stent. Let's listen the webinar with our best speakers. Thanks and welcome to all, sir. Thank you, sir.
Thank you, Dr. Munian, President ISA Puthukkottai City Branch. You have given an abstract of anesthetic implications of coronary stent. You have done the moderator's job. Now I request Dr. Kannan, our Secretary, ISA Puthukkottai City Branch, to offer the Secretary report. Kannan, unmute. Kannan, unmute.
Yes, sir. I'm audible, sir.
Yes.
Good evening, sir. Good evening to all. I am Dr. Kannan, Secretary, ASA Puthukkottai Branch. Successfully, we are conducting 6th webinar of Puthukkottai Budhan today. Today, our topic is coronary stent anesthetic implications. I welcome all our honorable speakers to the webinar. Last week, 19th February, our 5th webinar was conducted smoothly with enthusiastic speakers. The 5th webinar topic was basics of mechanical ventilation. This topic is very much needed and very useful to all intensivists and postgraduates. And then introduction to mechanical ventilation, indications and systemic effects done by Dr. Sri Lakshmi, postgraduate, Lady Harding Medical College and Associated Hospitals, New Delhi. And Dr. Sri Lakshmi has clearly explained the indications and the systemic effects by her amazing slides. And then the basic modes of ventilation with the graphics and asynchronity done by Dr. Nishant Kumar, Professor, Department of Anesthesiology, Lady Harding Medical College and Hospitals. Sir has explained basic modes very well by his different graphs. And then weaning from mechanical ventilation was done by Dr. Ansu Gupta, Professor, Department of Anesthesiology, Lady Harding Medical College. Ma'am has explained the weaning methods by the clearly with the criteria. And our moderator was Dr. Ranju Singh, Director, Professor and Head, Department of Anesthesiology and Critical Care, Lady Harding Medical College. Last webinar was attended by 928 delegates. Thanks all for your kind support, and we need your continuous support to continue this academic program. We ISA Puthukkottai thank our academic chairman, Dr. Meenakshi sir. We will aim 4-digit figure of delegates attendance in upcoming webinars by the consistency in quality. Thank you all.
Thank you, Dr. Kannan, Secretary, ISA Puthukkottai. Now it is my job of delivering this thematic address, and everyone know that Puthukkottai Budhan is a weekly webinar on every Wednesday conducting anesthesia-related subjects. Now the delegates attending are on the rise. And as our secretary pointed out, it is 928 last webinar, and hopefully we will crossing the 4-digit figure. So that is our aim. I don't know whether we will cross 5-digit figure when it is reaching 40th episode or 45th episode. I don't know. But last time the Lady Harding Medical College people participated well. And today we have a postgraduate, as it is customary in Puthukkottai Budhan to include a postgraduate younger generation speaker. So it is Dr. Vignesh. Dr. Vignesh is a Tamil Nadu person. So he belongs to Tamil Nadu and he did his UG in Sri Sathya Sai Medical College, Pondicherry, and he is doing his MD anesthesiology in Andhra Medical College. And he's the first point I want to tell, he is yet to be married. So he is a qualified bachelor. So many people are seeing him and he is quite handsome also. So I think Puthukkottai Budhan will fetch a pair for him. Not from Andhra, across the country now he is seen. Hopefully some people from Abu Dhabi has joined to see him or not, I don't know. but he is a good student and he is interested in sports also. Coco, badminton are his interested sports, and he is interested in analysis of cricket. So now he is doing analysis of all cricket matches, whether it is 50 over or 20 over. He is interested in geopolitics and he is interested in learning many languages. Now he is learning Telugu, or he has completed learning, I don't know. So he is in the process of it, and he is going to deliver a lecture on coronary circulation. So we welcome the youngest faculty of today, Dr. Vignesh, and it will be followed by Dr. Rajasekaran. Rajasekaran is so he has to become a chief and a professor in a government medical college in Tamil Nadu. He qualified his DA and MD from Tanjavur Medical College, and he was the assistant professor in Tanjavur Medical College. So I was his postgraduate, and just to bless us to have a early promotion, he left government service and he has gone abroad to Saudi Arabia. And 5 people followed him. Just because 5 people followed him, the 6th, 7th, and 8th people, I was the 8th. So we were promoted early, and we could enjoy the civil surgeon post for 18 years, which is unimaginable because the seniors have left us for the juniors. So I enjoyed the continuous promotions because of him. So he is a qualified instructor in BLS, ACLS. He is interested in academics. But just because he has gone, he was HOD in Majardah Hospital, Saudi Arabia, which happens to be a non-teaching hospital. So he has taught us here, and he was working there to earn wealth and health. So now, after coming back in the post-retirement era, the academic interest, which was subdued so long, it has again grown. And because of him only, this webinar is being conducted on coronary stent. He was very particular. He stimulated me, and as a young, energetic postgraduate, he practiced everything. He has sent his slides also to me. He again checked the slide share option. He is trained in the Zoom platform also. So with a lot of enthusiasm, he has come. So I welcome personally, sir. And I thank you for having given the way for us to get the promotion, I stress. And it is going to be followed by anesthetic management of coronary stent by Dr. Satish Kumar from Andhra Medical College. He is associate professor. He has done his MBBS in Rangaraya Medical College and MD post-graduation in NIMS, Nizam Institute of Medical Sciences. And even though he is in a government service, usually government service people will work only for salary, but he has done his postdoctoral fellowship in cardiac anesthesia and neuro anesthesia. That is a great thing. It should be appreciated because as a head of institution in a government medical college, I have seen only less interest among the chiefs once they attain that post. But this man has worked long, and he has 8 publications in indexed journals. He is a passionate teacher. So he offered to come because it is a collaboration for Dr. Rajasekaran, who has presented this chapter for the webinar. And so there, Dr. Vignesh and Dr. Satish Kumar have given helping hands. And then I thought one is from Tamil Nadu, 2 from Andhra Pradesh. So who is going to moderate? It is none other than Dr. Vijish Venugopal from God's own country. So he is a passionate cardiac anesthesiologist. Now it is just like a South Zone webinar. He is a passionate cardiac anesthesiologist, and you have to see to believe the way in which he administers anesthesia, because cardiac anesthesia is always complex. But with much ease, he is delivering that. At present, he is a principal KMCT Medical College, Calicut. And I happened to visit his college, and his college has obtained the NAC recognition because of his consistent effort. And naturally, his anesthesia department is doing very well, and they have arranged a CME also where I could participate. So the college ambience itself is very good. He is very particular in that. He is also a certified teacher in BCLS, ACLS. And as I said earlier in the informal chat, even though he is sitting in the administrative chair, he is always happy and he is ever smiling. So with the dimple in the cheek, he is attraction for the entire country, and he is one of the handsome anesthesiologists across the country. And I appreciate his commitment. And in addition to all these academic achievements, he is the state ISA secretary for Kerala. So ISA Kerala secretary is Dr. Vijish Venugopal. So whenever you go to Kerala, you please visit his college so that you will be having that inspiration. So with this introduction, I hand over the session to Dr. Vijish Venugopal. Sir, over to you, sir.
Good evening, sir. Thank you. Thank you very much for that kind introduction. And a very important topic has been selected today for a discussion on coronary stents, because every other day we will be facing people with coronary stents because of the rampant coronary artery disease that is happening. I would like to congratulate Puthukkottai branch for conducting this webinar regularly, and especially giving an opportunity for the young budding postgraduate students. That's a great thing that Puthukkottai webinar offers. And in fact, in Kerala, we too had a webinar, and I was one of the webinar coordinators at that time. So without any further ado, we will move on to the talks. We have lined up 3 talks, and the first one would be physiology of coronary circulation. And I would like to invite Dr.S.Vignesh, postgraduate from Andhra Medical Visakhapatnam, to deliver his lecture.
Hope I am audible to everyone out there, sirs.
Yes, you're audible.
Okay. A warm good evening to one and all out there. So myself, Dr. Vignesh, postgraduate from Department of Anesthesia, Andhra Medical College. Firstly, I would like to thank the ISA Puthukkottai branch and ISA Visakhapatnam City branch for this initiative and providing this opportunity to gain valuable experience from you people. Today, the topic of discussion will be about the physiology of coronary circulation. With your permission, shall I share the presentation from my side, sir?
Yeah, sure. Please do.
Hope the document is visible to everyone. Shall I proceed?
Yes, it's visible.
Okay. Topic of discussion is about physiology of coronary circulation. First, we'll be discussing in detail about the anatomy of coronary circulation, and then we'll be discussing the physiology of the coronary blood flow and its determinants. Coronary circulation, arterial supply and venous drainage. Arterial supply, we have 2 main coronary arteries, the right and the left. Left coronary artery, it arises from the left or the posterior aortic sinus and emerges between the pulmonary artery and the left atrium. It gives rise to 2 main branches, the left anterior descending artery and the left circumflex artery. Left anterior descending artery, it runs along the anterior interventricular groove, turns downwards and reaches the posterior surface. It gives rise to 2 branches, the septal and diagonal branches. Septal branch supplies the anterior interventricular septum and the anterior wall, and the diagonal branch supplies the anterior and the lateral wall. Left circumflex artery, it winds around the left lateral border and reaches the posterior surface. It gives rise to 2 branches, that is the left marginal artery and the posterolateral branch. Left marginal artery supplies the lateral wall, whereas the posterolateral branch supplies the posterior wall of left ventricle and left atrium, and finally it anastomoses with the posterior descending artery, which comes from the right coronary artery. In addition to these 2 branches, left circumflex artery also supplies the SA node in about 40% of the cases and AV node in about 10% of the cases. Coming to right coronary artery, it arises from the right or anterior aortic sinus and emerges from the pulmonary artery and the right atrium. It has 4 main branches, that is the right or the posterior descending artery, SA node artery, right marginal artery, and a posterior artery. The areas of distribution will be right atrium, majority of the right ventricle, excluding the interventricular septum. It supplies the posterior interventricular septum, and right coronary artery is responsible for supplying the SA node in about 60% of the cases and the AV node in about 90% of the cases. Bundle of S will be supplied by the right coronary artery. Now, moving on to venous drainage. Coronary sinus is responsible about 85% of the entire venous drainage. Remaining 15% is carried out by the anterior cardiac veins and the Thebasian veins. Coronary sinus, it opens into the posterior wall of the right atrium. The major veins draining into the coronary sinus are the great cardiac vein, which runs along the anterior interventricular groove, the middle cardiac vein, which runs along the posterior interventricular groove, small cardiac vein, which runs along the right coronary artery, and posterior cardiac veins. Anterior cardiac veins, it arises from the right atrium, and Thebasian veins, these are tiny veins which drains all the 4 chambers. These are also known as venae cordis minimi. Now, let us move into physiology of the coronary circulation. Coronary blood flow. Coronary blood flow is around 225 ml per minute, that is 60 to 90 ml per 100 gram cardiac tissue per minute. Total coronary blood flow is about 5% of the cardiac output, and a 3-fold increase can be noted during exercise or other strenuous activities. Maximal capillary density, that is about 15% of the mass. It has a maximal oxygen extraction of any vascular bed, 65 to 75%, whereas for other organs, it averages around 25 to 35%. Metabolic oxygen demand will be 10 ml of oxygen per 100 gram cardiac tissue per minute. Factors affecting myocardial oxygen supply demand balance. Factors affecting the supply are heart rate, coronary perfusion pressure, arterial oxygen content, coronary vessel diameter. Factors affecting the demand are the metabolic requirements, heart rate, wall tension, and contractility. Factors affecting supply. Decreased oxygen supply will be seen in conditions associated with increased heart rate. In conditions associated with increased heart rate, the duration of systole and diastole will be decreased. As we know, coronary tissues will be perfused only during the diastole. Since the diastolic filling time is decreased, there will be decrease in the perfusion. If there is decrease in the coronary perfusion pressure, there will be decrease in the oxygen supply. Conditions with decreased arterial oxygen content, seen in anemia or hypovolemia, it will lead to decreased oxygen supply, and decrease in the coronary vessel diameter, say for obstruction in the lumen, obviously there will be a decrease in the oxygen supply. Conditions associated with increased demand. If there is increase in the basal metabolic requirement, there will be increase in the demand. Increase in the heart rate and increase in the contractility will lead to increase in the demand. Increase in the wall tension will lead to increase in the demand. This can be explained by Laplace law. Laplace law is equal, that is, the tension equals pressure, that is a transmural pressure, into radius divided by 2 times the thickness. If there is increase in the intracavitary pressure and increase in the intra-residual volume, leading to increase in the radius, and decrease in the left ventricle wall thickness, it ultimately leads to increase in the wall tension. Now, determinants of coronary blood flow: coronary perfusion pressure, myocardial extravascular compression, myocardial metabolism, and neurohumoral control. Coronary perfusion pressure. It is the difference between diastolic arterial pressure and left ventricle end diastolic pressure. Any decrease in diastolic arterial pressure or increase in left ventricle end diastolic pressure causes decrease in the coronary perfusion pressure. Diastolic arterial pressure is the major determinant for coronary blood flow, whereas for other organs, mean arterial pressure will be the major determinant. Factors decreasing diastolic arterial pressure are aortic regurgitation and large patent ductus arteriosus. Factors increasing left ventricle end diastolic pressure are impaired filling of left ventricle, stiffness, decreased left ventricle ejection fraction, and delayed relaxation. Myocardial compression. Coronary blood flow is intermittent rather than continuous. This can be explained as follows. As we know, the coronary arteries, it starts on the epicardial surface and traverses through the layers, epicardial, intramyocardial part, and the subendocardial part. During systole, there will be contraction of both the ventricles, left ventricle and the right ventricle. As we know, left ventricle, which is around 3 times more thicker than the right ventricle, will be generating a pressure of about 120 millimeters of mercury. As a result, there will be complete occlusion of the intramyocardial and the subendocardial parts of the coronary arteries, leading to zero perfusion of the left ventricle during diastole. Whereas right ventricle, which is slightly thinner compared to the left ventricle, the pressure generated will be around just 30 millimeters of mercury, and there will be some amount of intramyocardial coronary arteries will be spared. As a result, some amount of perfusion will be allowed during systole as well. Hence, left ventricle is perfused only in diastole, whereas right ventricle will be perfused in both systole and diastole. As we know, subendocardial parts of the coronary arteries are more vulnerable to ischemia. Initially, we'll be seeing ST depression, which indicates there is ischemia to the subendocardial surface. Once the ischemia prolongs and the infarct develops, the epicardial, myocardial, and subendocardial, all 3 parts of the coronary are included. There will be development of transmural ischemia leading to ST elevations, that is STEMI. Coming to myocardial metabolism, the normal basal cardiac oxygen consumption is 8 to 10 ml per 100 gram cardiac tissue per minute. Maximum oxygen extraction ratio in myocardium is 75%. Unlike other organs, the maximum extraction ratio of oxygen will be around 25 to 35%. In conditions of increased demand, it will be increased further and reaches a maximum of 75%. Whereas in myocardium, it already attained the maximum extraction ratio of 75% for adequate perfusion. If at all there is an increase in oxygen demand, the extraction ratio cannot be prolonged further. Hence, increase in the oxygen demand is met only by increasing the coronary blood flow. This is known as the flow metabolism coupling. Oxygen consumption for various activities are as follows. Basal activities 20%, electrical 1%, volume work 15%, and pressure work 64%. Any increase in the metabolic demand is met only by increase in the coronary blood flow. The factors affecting the flow metabolism coupling are adenosine, potassium ATP channels, reactive oxygen species, hydrogen peroxide, oxygen, carbon dioxide, and nitric oxide. Berney hypothesis. According to Berney hypothesis, if there is increase in the demand, there will be increase in the metabolism, which leads to degradation of the adenosine nucleotides. As a result, there will be increase in the extracellular adenosine levels, which leads to vasodilation. As a result, there will be increase in the coronary blood flow. Adenosine is the most important factor for increase in the coronary blood flow resulting from vasodilation. Moving on to autoregulation, it is a tendency for organ blood flow to remain constant despite changes in arterial perfusion pressure. Pressure maintained between 50 to 120 millimeters of mercury by myogenic and metabolic mechanisms. Myogenic mechanism, increase in passive stretch on vessel causes active increase in vasoconstriction and vice versa. If at all there is a decrease in the blood flow, there will be decrease in the passive stretch on the vessels, leading to vasodilation, leading to increase in the coronary blood flow. Metabolic mechanism, hypoxia, which leads to release of adenosine, and it causes an increase in the coronary blood flow. Hypoxia is the critical mediator for coronary blood flow autoregulation. Gregg effect, it is the myocardial contractility and metabolism increases when coronary pressure is greater than the normal autoperfused level, that is more than 120 millimeters of mercury. Last, neural control. Autonomic influences are generally weaker. Both alpha-1 and beta-2 adrenergic receptors are present in the coronary arteries. As we know, alpha-1 receptors are primarily located on the larger epicardial vessels, whereas beta-2 receptors are mainly found on the smaller intramuscular and subendocardial vessels. Alpha-1 receptors, though they produce vasoconstriction, it also produces secondary effects like vasodilation, thereby increasing the coronary blood flow. Beta-2 receptors, the primary actions are vasodilation and increasing the contractility, resulting in increase in the coronary blood flow. Sympathetic stimulation generally increases myocardial blood flow because of an increase in metabolic demand and a predominance of beta-2 receptor activation. The sympathetic input arises from the superior, middle, and the inferior cervical ganglion and the stellate ganglion and thoracic segments T1 to T4. Parasympathetic effects on the coronary vasculature are generally minor and weakly vasodilatory. Parasympathetic vagal stimulation, it will lead to decrease in the heart rate and it will lead to decrease in the coronary blood flow. Vagal blockade, it will lead to increase in the heart rate and there will be increase in the coronary blood flow. Thank you, everyone.
Thank you, Dr. Vignesh, for that comprehensive talk on the physiology of coronary artery circulation. We'll take up any questions towards the end of all the three talks. Next, we have with us Dr. Rajasekaran, sir, and sir will be talking on coronary stents. Over to Rajasekaran, sir, for his talk on coronary stents.
Thank you very much. First of all, I want to thank and congratulate Puthukkottai ISA and Dr.Meenakshi. And I also welcome all my co-participants. I am very thankful for help for getting this topic on air. Now I will start my topic. I would like to share my screen. Hope you are able to see my screen.
Yes, sir, it is visible.
Thank you. This is our great Thanjavur temple, photograph taken by me during my last visit to Thanjavur. My topic is coronary stents. I have made it very simple and comprehensive for the sake of DA postgraduates, and I think professors will agree with me. Let me introduce about the coronary disease and the coronary stents. Coronary artery disease has become a common occurrence in people. Sorry. You are able to see my screen?
Yes, sir, it is visible.
Coronary artery disease has become a common occurrence in people nowadays. Such patients invariably undergo PCI, percutaneous coronary intervention. PCI includes angioplasty and a stent placement. These patients are put on long-term anticoagulant therapy. An average of 600,000 patients are undergoing PCI per annum in the USA. The reported incidence of non-cardiac surgery after PCI ranges from 4% to 11% in 12 months. 7% to 34% in 24 months. Let us define what is a stent. A stent is a small mesh-like metallic device which acts as a support or scaffold in keeping the vessel open. Stents help to improve the blood flow to the heart muscle and reduce the pain of angina. Coronary stents have revolutionized the treatment of coronary artery disease. Patients who come for non-cardiac surgery pose a greater challenge to the anesthesiologist and the treating physician as there is increased risk of morbidity and mortality. We have to balance between hemorrhage and thrombosis as these patients are on long-term anticoagulant therapy. This picture I made from ChatGPT using artificial intelligence. It has given an expanded picture about the stent. I think you may appreciate it. Let's go to the history. Percutaneous transluminal coronary angioplasty was by Grunzig in 1977. Puel and Sigwart in 1986 deployed the first coronary stent to act as a scaffold. In 2001, drug-eluting stents were introduced as a strategy to minimize restenosis. How do the coronary stents work? To make it simple, angioplasty is done. A small balloon is inflated to widen the narrowed artery and the stent placement. The stent is inserted along with the catheter, which is expanded to keep the artery open. The balloon is deflated and removed along with the catheter, leaving the stent in position. Blood flow is restored freely through the stent and coronary artery disease symptoms reduce. This is a picture showing the left coronary artery. You can see the narrowed artery and the stent along with the balloon and the catheter is introduced in the narrowed portion. In the second picture, you can see the balloon is inflated and stent is expanded. In the third picture, you can see the balloon and the catheter has been removed and the stent is left in situ. There are three types of stents. One is bare metal stent, otherwise called as BMS. Second, drug-eluting stents or DES. Bioreabsorbable stent, otherwise called as BRS. Something about bare metal stent. It is made of stainless steel or cobalt chromium or platinum chromium. Re-endothelialization occurs within 12 weeks after placement of this stent. This stent is used in patients who are non-compliant for long-term antiplatelet therapy, patients who have bleeding disorders, or patients who are waiting for immediate non-cardiac surgery. I'll tell the reason in the following slides. It is not used extensively nowadays. Drug-eluting stents consists of a metallic scaffold coated with polymer carrier vehicle that stores anti-proliferative agent. The carrier releases the drug in a gradual, controlled fashion into the intima of the vessel. It prevents neo-intimal hyperplasia encroaching the lumen. So, it prevents the incidence of restenosis in the first year of the stent placement. Second and third generation stents are in common use. Anti-proliferative agents used are sirolimus and paclitaxel. There are some pros and cons about drug-eluting stents. Positive things, there is improved flexibility of the stent. They have thinner struts, enhanced polymer biocompatibility, and better eluting kinetics. The points are against or points with some problem are presence of permanent scaffold platform, lack of reactive vasomotion, neoatherosclerosis, and increased rate of reintervention. Bioreabsorbable stents. They are made of biodegradable material like polylactate scaffold coated with polymer for drug elution. After 12 months of drug elution, either the polymer or the scaffold coated with polymer is reabsorbed. Less local irritation and inflammation is there with the stent. So there is improved chances of healing. So there is reduced risk of stent thrombosis. It preserves the normal physiology of the blood vessel after reabsorption. In case needed, restenting is easier in these patients. General response to angioplasty and generic response to angioplasty and stent placement. Immediate vessel wall recoil, negative arterial remodeling, and neo-intimal hyperplasia. Vessel recoil and negative remodeling is prevented by the presence of a stent. Drug elution prevents neo-intimal hyperplasia. There is a period of risk after stent placement, the risk of stenosis and thrombosis. With bare metal stent, it is 30 days is the timeline. For drug-eluting stents, 6 months, and bioreabsorbable stents, it extends up to 12 months. Anticoagulant therapy following stent placement. It is a must. Dual antiplatelet therapy is initiated after stent placement. Aspirin, a COX-1 inhibitor, is used lifelong. Along with aspirin, any one of the following drug is used. Clopidogrel and prasugrel, irreversible binding to P2 vital receptor via active metabolite. Ticagrelor and cangrelor, reversible binding of P2 vital receptor. Oropaxar, reversible binding of PAR1 receptors. Abciximab, tirofiban, eptifibatide, they are reversibly binding to glycoproteins. All the above drugs, any one of the drug is used with aspirin up to 1 year. There are complications with the stent, as I already mentioned. The complications are more common with bare metallic stents. Restenosis. Restenosis is one of the complications. It involves gradual narrowing of the stentic segment immediately proximal or distal to it due to neo-intimal growth. Second complication is thrombosis. Third one is allergic reaction. Drug-eluting stents reduce the incidence of stent restenosis. Stent thrombosis is a medical emergency. Stent thrombosis is the formation of a blood clot within the stent, which can block the blood flow to the cardiac muscle. Timing of the thrombosis, it is called acute when it occurs within 24 hours of stent placement, subacute from 24 hours to 30 days, late 30 days to 12 months, very late more than 1 year. Causes of stent thrombosis: inadequate stent deployment, inadequate antiplatelet therapy, stent malposition, stent fracture, and patient factors like diabetes, kidney disease, smoking, non-compliant to antiplatelet therapy. Signs, symptoms, diagnosis, and treatment of stent thrombosis. Patient may have chest pain, breathlessness, lightheadedness, fatigue. It is diagnosed by angiography, electrocardiogram, and echocardiogram. According to standard treatment advised, according to the situation of the patient, emergency angioplasty, thrombectomy, antiplatelet therapy, anticoagulant therapy, according to the condition. Prevention of stent thrombosis, dual antiplatelet therapy is advised. Regular follow-up of the patient is essential. Advice of healthy lifestyle like quit smoking, exercise, diet, everything, etc. Now we have seen about the stent and the complications. Let us know about the timing of non-cardiac surgery after stent placement. In stable ischemic heart disease with low thrombotic risk, delay non-cardiac surgery for 6 weeks after bare metal stent. 3 months delay with drug-eluting stents and aspirin being continued throughout. Patients with PCI during acute attack or high-risk thrombosis delay the non-cardiac surgery for 6 months regardless of the stent type. Patients with reabsorbable stents, 12 months delay of non-cardiac surgery is mandatory regardless of the indication of PCI. In case of emergency surgery, we have to proceed with the surgery, taking the risk of cardiac and thrombotic events. As an anesthetist, I will be aware of the risk and complications, maintain the balance between hemorrhage and thrombosis, plan the timing of non-cardiac surgery and management of dual antiplatelet therapy, cooperation with multidisciplinary specialties for bringing out the best and safest outcome. Thank you. This was the picture taken by me in Velachery Lake, Chennai recently during the rainy days. Thanks a lot.
Thank you, Rajasekaran sir, for that comprehensive talk on stents and how we can go about when we have a patient with a stent. So next we move on to the next talk of the day, that is on the anesthetic management of a coronary stent patient who will be coming to us for non-cardiac surgery. And to deliver that lecture, we have with us Dr. P.Sateesh Kumar, who is the Associate Professor at Andhra Medical College, Visakhapatnam. Welcome, sir. Over to you.
So thank you, sir. I am audible, sir. Am I audible?
Yes, you're audible.
Yeah, thank you, Meenakshi sir and Puthukkottai, the webinar committee organizers and others colleagues for this great opportunity. Can I start sharing the presentations? Starting. Huh? Start sharing. Okay. Full screen also. Can you see, sir?
Yes, sir. You're visible.
Yeah, I will proceed. Thank you so much, sir. Yeah, in this talk, right now, Vignesh sir and Rajasekaran sir discussed about the coronary anatomy, physiology, and stents. Just I am continuing with this same topic for the anesthetic management part. Anyhow, some of the slides I can, same slides can, I think I am also having the same slides. And most of my presentation is from the latest guidance of 2024 American Heart Association and European Council, the recently published guidelines. Just I am sharing some of the guidelines with the video. So as all of us know, anesthetic management of post-cardiac patient for the post-PTCA for non-cardiac surgery is a double-edged sword. So basically, we have to balance the risk of thrombosis versus bleeding. That is the main challenge for us, basically, when to stop and when to start. And apart from that, we have to look for the other cardiac problems in cardiac associated conditions. So in this picture, we have seen we have to make a balance between the demand and supply. At the same time, we have to, as a surgery is a hypercoagulable state, it is a stressful state. Patient can be landed up in the hypercoagulable state.
So can we go to slide? Can we go to slideshow, sir? Slideshow? Can we go to slideshow?
It is slideshow only. It's not getting, sir. Okay. Now, just 1 minute. Can I share again, sir?
Yeah, please.
No, sir. What you have done, you have opened the PowerPoint.
Yes, sir.
But you have clicked the main portion. You have to, there will be two things will be seen. One is a PowerPoint, another is a PowerPoint slideshow. You have to click that slideshow.
Yes, sir.
So you can just go out of this and go back and share the slideshow part.
Share already. Yeah. Okay, person.
Dr. Satish, you stop sharing.
Yes, sir.
Then you select that screen share.
Stop. Yeah. Is that? Now it is okay, sir?
Yeah.
Yes.
Okay, thank you so much. Next slide. Stop share.
No, now it is screen share is full, slideshow mode only.
No, no, I am not
Move
going
the
to.
second slide and see whether it is coming or not. Move the-
No, I am getting, but the thing is, next slide.
ClearNet, can you help? ClearNet.
Sir, I think you just, yeah, okay. Now we'll do it once again. It'll
Yes,
become
sir.
all right.
This one, no? Slideshow.
Yeah, slideshow, you share the slideshow part. Can I go to the second slide and see whether it's moving?
It's not moving, sir. That is the problem.
No, again, that means you are sharing, you just see the slideshow icon will be there. Two screen will be open. One will be having a big P, another one is having a small P. You have to click that small P only.
Share it. Stop share.
ClearNet, you are available.
ఇది మామూలు ఇక్కడికి వెళ్తే
So you share the second one, not the first one which you shared here.
Okay. Stop it. PPT. Very disturb. ఇదే కదా ఎక్కడ PPT స్టాప్ లోనే ఉంది. పెట్టలేదు కదా నేను ఇందాక పెన్ డ్రైవ్ పెట్టాను.
Sir, should I help you out with the sharing process?
Yeah.
Yeah, please do help.
Okay, sir. So have you opened the PPT? New
Yeah,
system?
just time.
Dr. Sateesh, you listen to ClearNet.
Yes, sir. Yes.
Yes, sir. Now it is sharing. Yes, sir. It is now visible. Sir, can you make it full screen?
Yeah. The problem is I am not going to the next slide. Yeah, now it is getting. Okay, thank you so much. Yeah. Sorry for this. Okay.
Actually, it is not.
So now it's okay.
No, you have to go to full screen.
Slides.
It is full screen only. No.
Yes, we will leave it. Dr. Vijish, we will leave it. I think there is a problem now. It is moving.
It is moving. We'll continue like this, sir. No problem.
Okay, sir. Okay, thank you.
Sateesh, sir, will continue in this.
Okay. Okay. So we have to look into the perioperative risk factors like elderly age, acute coronary syndromes, history of diabetes, renal impairment, anatomical factors, and also the type of stent, longevity, the left main stent or ostial stent are the things. And we have to return. There are two things for us. One is whether the stent is, we have to consider for the thrombotic risk. At the same time, we have to consider for the bleeding risk. So based on the, how do you plan whether the patient is thrombotic risk, depending on the already the Rajasekaran explained, with a low risk category, with less than 1%, like patient with post balloon dilatation with more than 4 weeks, and bare metal stent with more than 6 months, and drug-eluting more than 12 months. So if the patient, if the patient is having these criteria, we consider as a low risk category. The patient had coming with intermediate category 1 to 5%, just whatever there in the 2 to 4 and 1 to 6 and 6 to 12. The high risk category, if it is more than If it is less than 2 weeks for balloon and less than 1 month for bare metal and less than 6 months for the drug-eluting stents. And coming to the hemorrhagic risk, so in that we consider the thrombotic risk. Coming to the hemorrhagic risk, depending on the surgery, whether what type of surgery, whether it comes in low risk category, intermediate risk category, high risk category. Like a hernia, plastic surgeries, hernias, all this comes in low risk surgeries. Intermediate surgeries like a major abdominal aortic surgeries and bariatric rectal resections, thyroid comes under intermediate risk. High risk surgeries like open thoracic surgeries, hepatic resections. So depending on the surgery factors, we consider as a intermediate, low and high risk. And depending on the duration of the stent, from the placement of the stent to the timing of the procedure, considering as a intermediate, low and high risk for the thrombotic risk. So anyhow, I am skipping this antiplatelet agents.
So actually, we are not seeing those slides.
Yeah, what is it? Huh? Good.
Okay, now antiplatelets have come.
It's coming, sir.
Okay, now it's moving. Yeah.
Hmm?
Yeah, it's moving.
Now it's coming, sir.
Yes.
Okay, so an antiplatelets anyhow, I am not just for routinely using aspirin and platelet aggregation inhibitors like ticlopin, clopidogrel, and prasugrel, and ticagrelor, and voraprexa. And IV antibiotics, why it is important is for making the bridging therapy. So these are the short-acting IV antibiotics. So routinely we are using the tirifovir, reptifem, and recently cangrelor also came. So among all the things, so offset of plasma half-lives are very short for almost around 2 hours to maximum of 3 to 5 hours. And now coming to the risk assessment. How do you assess the risk in these patients? Okay. These are the slides taken from the American Heart Association latest guidelines. So we may consider for the Goldman Risk Index, Revised Cardiac Index, and also surgical outcome risk tools and NSQ-based surgical risk calculators. And also we have to think, consider for the functional capacity. Functional capacity is routinely assessed by at the bedside also. We ask the patient to walk along with us. We may ask them in the floor. In the corridor, we ask the patient to come along with us, or we will ask him to climb of stairs along with us, so that if he can make up a flight of stairs comfortably, 2 flight of stairs, we consider as a 4 minutes. And also we will there is a questionnaire, format of questionnaire with the Duke's activity index also we will take into consider. If it's more than 34, they maybe doesn't need any further evaluation. And also coming to the fertility recommendations, where depending on the all patients with fertility who are undergoing elective risk non-cardiac surgery, preoperatively fertility assessment using validated tool can be useful. This is added in the latest guidelines. Now, another scoring system is DAP scoring. This is particularly useful for the patients who are on the post-PTCA patients on antiplatelet agents. There are different points, criteria will be there, age and diabetes and smoking, prior PCA and MI. So if the DAP score is more than 2, that is, these patients are more chance of thrombotic. If the DAP score is less than 2, these patients are more prone to the bleeding. So we have to consider whether we are taking this patient maybe going for the more bleeding episodes or more thrombotic episodes. If it is between the -2 to +2, maybe we will say this can be happily taken up for surgery. And also the latest guidelines, it is they given the biomarkers also like BNP and pro-BNP. So they have recommendations of class 2A. So in patients with known cardiac disease, the elderly is and symptomatic suggestive of this, for BNP measurement and pro-BNP before surgery, supplemented evaluation of the perioperative risk rates. And also cardiac troponins in patients with known cardiac vascular disease greater than 65 years is more than 45 years, symptoms suggestive of undergoing elevated risk. If it is positive, we may suggest for before taking up the surgery, we can consider for the taking for the BNP and pro-BNP and troponins. Whether the patient can need stress test. So patient had underwent stenting maybe 1 year back or 2 years back, may can have regular follow-ups or not, we don't know. So we doesn't need all the patient needs stress test. Technically, some of the patients, so we have to decide whether we're taking for, if it is a major cardiac surgery, we may go for the stress echo. Just like that, if the patient have functional capacity is good, more than 4 minutes, and very minor surgery like a hernia, and low risk, and also where the DAP score is normal, within normal, low risk of perioperative events, doesn't need any stress test. Suppose if the surgery is a major surgery like a Whipple's procedure or major any malignancy, any onco surgeries, and also patients have dual antiplatelets and the risk of some any comorbidities, we may consider for the stress testing. And also, we can have the patients with osteoarthritis where they cannot do the regular treadmill test. They can go for the Doberman stress echo. Only contraindications, like in critical aortic stenosis and hemodynamic significant livelihood obstruction may be contraindication for this stress testing. And also, what is the stepwise approach? Basically, this is in general they're given a guidelines for the coronary artery disease. It is not is a cardiac patient for non-cardiac surgery. But as a whole, this post-PTC patient is also comes under cardiac surgery category only. So whether we have, how do we approach the patient? Patient came with a post-PTC. So we are planning any surgery. So what is your approach to the patient? Whether the surgery is emergency or elective. So emergency is, suppose if the patient have with cardiovascular risk factors and symptoms, no symptoms, we may go for surgery. If it is emergency surgery and patient have history of MI, history of acute coronary, history of unstable arrhythmias, any decompensation of heart failures, then you have to think for it. You have to work up the patient. If all the patients in present, then you have to think and work with the directed medical therapies. And if there is no symptoms, but it is emergency surgery, and patient have like a classical patient have post PTC or post ABGs, then you have to calculate the risk and we will go for the further evaluation. And also we can continue the modify whether the patient have modifiable risk factors or low risk factors. The low risk factors we may consider. So doesn't have much. He has a normal control sugars. He has normal blood pressure. No any other symptoms. We may go for surgery. Suppose if the patient had, we can give some time. If it's not emergency surgery, some modify. We can modify the risk of it. Suppose the patient is smoking, we may ask for that at least for 2 to 3 weeks. Or if the patient have uncontrolled sugars, at least we can wait for 2 to 3 days. We can normalize the sugars. So if the patient have modifiable risk factors are present, we may optimize. If the patient have low risk factors, we will go for the surgery. If the patient have regulated risk factors and no modifiable risk factors, we may consider for the further workup of the patient, consider ECG, and if needed, we may go for the coronary angiography also. And also, as earlier said, in the role of biomarkers, whether BNP, pro-BNP, and troponins are abnormal, we need multidisciplinary treatment. If they are normal, we may go for the surgery. What are the perioperative medical therapies? So these are all recommendations that are taken from the guidelines only. So statins, as all of us know, always will continue statins. The patient is on statins, or we can if you want to start also, we can start the statins also. And coming to the renin-angiotensin or aldosterone inhibitors, the recommendations is these patients with controlled blood pressure undergoing elevated risk of non-cardiac surgery or chronic medications holding 24 hours prior to surgery may be beneficial. So if the patient with AC inhibitors, these patients we can hold for 1 day before surgery. And coming to the alpha clonidine like medications, initiation of low dose clonidine perioperatively is not at all recommended. So technically, statins should be continued. RAC drugs should be stopped 24 hours before surgery. And coming to the beta blockers, as all of us know, beta blockers definitely useful for the perioperative period. There is a class 1 recommendation. Patients undergoing non-cardiac beta blocker should be continued with the class 1 recommendation. And coming to the management of dual antiplatelet drugs. So what is our approach? Till now, we have the medical management. Now coming to we already assessed the thrombotic risk and bleeding risk. Now we're coming to this patient is planning for the surgery. So perioperative management of dual antiplatelets, sir already explained in the previous class. Just for continuation sake, I'm explaining in this slide. If all of you observe, there is a chance of hemorrhagic risk low, intermediate, and high, and thrombotic risk also we consider as a low risk, intermediate risk, and high risk. If the hemorrhagic risk is low and thrombotic risk is low, we will continue the aspirin, and just we will discontinue the by12 inhibitors because there is a less chance of thrombotics. Suppose if the hemorrhagic risk is low and patient is a high risk for thrombosis, if surgery is non-deferable, we have to continue both the postpone. If the elective surgery, we have to postpone. If the surgery is non-deferable, we have to continue medications to prevent the thrombotic risk. At the same time, if the intermediate risk category, postpone the low risk bleeding, intermediate risk thrombosis, postpone elective surgery. So take home message is postpone elective surgery for the intermittent high risk of thrombosis. If the patient hemorrhagic risk is low, suppose if the hemorrhagic risk is intermediate, we have to continue aspirin. and discontinue the PY2 inhibitors. And thrombotic risk is intermittent and high, you have to postpone the electrosurgeries. Suppose if the both hemorrhagic risk is high and thrombotic risk is high, postpone electrosurgery. If surgery is non-defendable, continue all the medication, the aspirin, and discontinue these inhibitors and resume within 24 to 72 hours with a loading dose. Consider the bridging therapy. So here the hemorrhagic risk is high and thrombotic risk is high. We have to consider for the bridging therapy. This is the situation where we have to stop the oral anticoagulation and we have to initiate the bridging therapy, particularly in the patients with high risk of hemorrhage and high risk of thrombosis. So now this is the, so what are the commonest medications for the bridging therapy? So we can use small molecule GP2B3A inhibitors, or we can use the ticagrelor cangrelor. So if the patient is prasugrelor of the patient, you have to stop like we have like a brilliant like medication, we have to stop 7 days in prasugrel. If the clopidogrel, we have to stop 5 days before surgery. After, and you can see the table clear cutly. So from the 0 is the time of surgery. From the 7 days before, we are stopping the prasugrel. 5 days, if the patient is in clopidogrel and ticagrelor, we are stopping the 5 days before. And from the 3rd day, so just all of observe the slide. So 1 week before for the prasugrel, 5 days before for the clopidogrel and ticagrelor, and we are stopping the medications. We are starting the intravenous medications like tirofiban from the 3 days before the surgery. And we are stopping the medications just 4 to 6 hours before the surgery. So we are continuing the infusions from the 3 days before surgery, and we are just stopping the medication just 4 to 6 hours surgery. Once surgery is completed, if you are not, and there is no bleeding risk, after 4 to 6 hours, you can resume the same medications. And basic thing is, after follow-up medications should be given with a loading dose. Just remember, if the patient is clopidogrel, if the patient is ticagrelor, so don't start with a regular dose of 75 milligrams. Always start with the loading dose of again 300 mg or 600 mg. Loading dose should be given after the resume, after the surgery is over, and you are not expecting any bleeding complications. Okay. And this is about a cangrelor. In cangrelor also, we start from the 7 days before, and we will stop between 1 to 6 hours before, and we will follow up resume after 4 to 6 hours. Now coming to the timing of surgery, sir has already explained clear-cutly. So balloon angioplasty 14 days should be done after 14 days. PCA, bare metal stent PCA, at least minimum time is 30 days. Drug-eluting stent is with the patient. So in the drug-eluting stent, the patient with a chronic coronary disease or acute coronary syndromes, you have to think of. Some patients with acute MI, they have primary PCA and acute coronary syndromes, where delay for the non-cardiac surgery is more than 12 months. But in case of chronic coronary disease, these are the latest guidelines, given in the 24, where they mention the PCA, drug-eluting PCA, for what purpose it is given, whether for the acute coronary syndromes or for the chronic coronary disease. If it is a chronic coronary disease, they mention 6 months. If the stent is placed for the acute MI, acute coronary syndrome, you can have to wait for 12 months. The chronic coronary disease, you have to make for the 6 months. So this is the take-home message in this slide. So we have to think the drug-eluting stent, what type of stent was placed in which indication, whether it is acute or chronic. Suppose if the surgery is, you can, if the delay non-cardiac coronary surgery for more than 3 months after DEs, PCA, time-sensitive indication surgery, you can postpone. The surgery is not emergency, you can postpone up to 3 months in acute coronary syndromes, whereas in the same, you can delay surgery for more than 3 months. Sorry. Now coming to the intraoperative monitoring. What is the monitoring tools for any cardiac patient? Technically, we are dealing with the post-PTCA patient for cardiac surgery. So technically, all of us use routine monitoring is important for oximetry, ETCO2, temperature. ECG is the mandate. So why you have to do ECG? We have to detect the ongoing ischemia. We have to identify the intraoperative or perioperative MI. So actually Retd is 5-lead ECG with ST segment analysis is superior, and multiple lead monitoring is more sensitive, and lead 2 and V4 can detect the 80% of the ischemic episodes, and adding V5 may detect the 97% of the intraoperative MI. So 5-lead ECG with ST segment analysis is mandatory for any patient with post stenting for non-cardiac surgery. So invasive blood pressure, whether needed or not, it depends. Actually, for a small surgery like a hernia, hydrocele doesn't need any invasive monitoring. And CVP also, if you are suspecting any major fluid shifts and like a Whipple's procedure, you may consider for the CVP and arterial blood pressure. Another doubt whether the patient, some of the major procedures like oncosurgeries and major resections, whether you have to keep echocardiography like TEE for detecting ongoing ischemia, or whether to go for the pulmonary artery catheterization. So what the recommendations given is TEE are focus available to assess the cause of unexplained hemodynamic instability. Suppose the patient during the procedure, you are giving a lot of fluids, patient is continuously severe hypotension, you doesn't need the know the cause of unexplained hypotension or unexplained cardiac events on table in a major cardiac surgery, you may consider for the routine use of TE. At the same time, you may consider for the pulmonary artery catheterization in hemodynamically significant conditions with patients with history of cardiovascular disease undergone TA's routine pulmonary artery catheter generally not recommended, and make sure that temperature is maintaining normothermy is also very, very important. So monitoring is used if acute or severe hemodynamic instability and cardiopulmonary dysfunction prior to urgent or emergency surgery, you may consider for the echocardiography and pulmonary artery catheterization. And this is the ECG showing for the post leads. So which lead is when you're detecting this, you have to ongoing ischemia. Maybe you have to leave for the lead one and AVL for the circumflex leads, anterior leads V1 and V2, and for the lateral leads also V5, V6, and lead 2, 3 AVF for the inferior leads or right coronary artery. So any patient on ongoing chest pain, if they're complaining of inferior wall MI or any ST elevations or any changes in the lead 2, 3 AVF, you may consider for the right coronary block. The patient had any leads when anterior leads when V2, V3, V4, and septal leads also, you are suspecting the LAD territory block. At the same time, in lead 1, AVL and V5, V6, you have to suspect the circumflex artery is involved. Choice of anesthesia, technically, depending on the surgery itself, doesn't make any difference whether you are giving general anesthesia, whether giving the regional anesthesia. Make sure that if the you have to maintain the hemodynamics properly, there should not be major hemodynamic changes throughout the surgery. Whether you administer GA, whether you administer regional anesthesia. Suppose if the surgery is below umbilical surgery or orthopedic surgery, you can happily consider for the regional anesthesia. If the LV function is good, you are not suspecting any cardiomyopathy like thing, any EF is low. Otherwise, if the normal patient with post-PTC, you happily go for the regional anesthesia. If the surgery itself indicates for needs for general anesthesia, you may consider for the general anesthesia. In class 2A recommendations, in patients with undergoing non-cardiac, the use of volatile-based anesthetic or TIVA reasonable for general anesthesia. At the same time, in patients with undergoing non-cardiac, the neuro anesthesia is available. Either neuro axial or general anesthesia is reasonable. So, in recommendation purpose, whether you use general anesthesia or regional anesthesia doesn't make any difference. Coming to the anesthesia management, the pre-medication, as all of you know, will give fentanyl and midazolam, and we have to maintain the pre-oxygenation with 100% oxygen is mandatory because these patients may going hypoxia is a cause for the threshold for the ischemia. So always maintain make sure that the always maintain the oxygenation, pre-oxygenation, and induction. Etomidate is a cardiac stable drug you can use. If it's not, if the patient is LV function is good, you may consider for the propofol. But ketamine technically will increase the sympathetic activity unless really needed in a shock patient. Technically doesn't useful in cardiac patients. Intubation, stress response to the laryngoscopy should be avoided. With a smooth response, give with opioids and lignocaine, and small, very plus attempts, and always make sure that you can spray with the vocal cords with xylocaine spray, and we can give bolus of xylocaine, IV intravenous xylocaine. And also before intubation, we can increase the depth of anesthesia or give extra dose of propofol to make the hemodynamic response less. And maintenance, you can use the regular maintenance dose of either sevoflurane and oxygen nitrous oxide. Volatics anesthetics have cardioprotective effects and may not be significant in non-cardiac surgery patients. So don't do hyperventilation and don't avoid hypocapnia. Maintain BP. So the take-home message is blood pressure should be within 20% of the normal values. And make sure that good analgesia and adequate depth and NSAIDs, you can supplement the opioids with NSAIDs also can be useful. And a word about the anemia management. Actually, CAD patients with a low HB more prone for the ischemia. As a recommendation here, what he is given is in patient with undergoing non-cardiac surgery, we expect blood loss. Tranexamic acid is the reasonable tool. Just I am wondering actually why he is mentioned tranexamic acid, because already the post-PTCA patients also, and he clearly mentioned that an antifibrillary has been shown to be safe even with high-risk patient with history of venous thrombolism, prior MI, and prior ischemic stroke. Just I will give to the house whether we can use tranexamic acid or not after this end of the session. And this is the recommendation from the perioperative anemia. Always make sure that HB should be above 10 is ideal. If needed, we can transfuse blood transfusions. Otherwise, we can optimize the patient before going for the surgery by increasing the hemoglobin values. Extubation, nowadays we are using the Sogamdex. We can use the regular neostigmin with glycopyrrolate. Always extubation should be smooth. Make the deep plane and extubate safely. A word about the perioperative MI. This is very, very important. So any risk of MI peaks within 72 hours after surgery in most events occurring on the day of surgery in the next 24 hours. So according to WHO definition, the patient having typical ischemic chest discomfort, any elevated serum creatine kinase or isoenzymes, troponins, and typical ECG findings, you have to suspect the perioperative MI. You can manage with oxygen, good pain relief. You can start with NTZ. You can start with the antiplatelets, depending on the surgery. And also you can use the unfractionated heparins and beta blockers. If there is a significant tachycardia, you can use the beta blockers. And a word about the perioperative MI. Acute MI, after evidence of possible MI, you have to take the history, physical examination, and follow ECG, and also ST augment. After the ST augment, after surgery, you are suspecting MI, you take the ECG. You have to see the criteria, whether the patient had elevated ST segment or not. If ST segment elevated MI, you have to go for the goal-directed medical therapy and refer to the expert person, or may plan for the PCI or revascularization. If the patient no ST segment and operative and ST segment criteria, no ST segment elevation, but there is a significant criteria for MI is met, and patient had symptoms, but there is no ST segment, and you have to think for the non-ischemic process is going on, whether the patient have major cardiac event after non-cardiac surgery or non-ischemic myocardial injury. If the patient had criteria for MI and segmental elevation of MI, and you maybe suspect plaque rupture or not, whether yes, you can go for the type 1 and STEMI. There is no suspected plaque rupture, type 2 and STEMI, and treat the underlying cause. So anything you have to think of when the post-operative, you have to observe the patient in at least for 48 hours to look for the perioperative MI. And post-operative pain management is absolutely needed, whether you can go for the epidurals, thoracic epidurals, or lumbar, depending on the surgery, other lumbar epidurals. At the same time, nowadays we are having the drug-coated patches. Fentanyl patches are doing very good job, and any drug patches are very useful in the post-operative phase. Absolutely, patient should be pain-free in the post-operative phase. That again will stimulate the post-operative MI. So what post-operative care would be? Continuous ECG monitoring is mandatory, and continue use a beta blocker, good temperature control. You provide a supplementary oxygen and adequate post-operative pain relief. Particularly DVT prophylaxis is mandatory, particularly in the patient with the hip replacement surgeries, TKRs, where they are bedded in patients. Even though you can start with the antiplatelets medications, apart from that, the DVT and the low molecular heparin may be indicated in these patients. In a conclusion, the incidence of IHD is increasing, and you have to take home and think of the possibility of continuation versus stopping the anticoagulation medication, and when to restart the anticoagulation medication, antiplatelet medications, and also any modifiable risk factors can be optimized prior to that. And never required, the further testing has to be ordered, since there is a team effect who have to involve the cardiologist, surgeon, and treating physician. And all antifailure medications, beta blockers have to be continued throughout the perioperative period. For anesthesia guidelines have to be, as for new ASTRA guidelines should be followed, and factors which after the myocardial oxygen supply demand could be taken care of. And monitoring is important to detect early ischemia and rhythm disturbances, and post-operative pain is another important aspect. Hence, proper evaluation and management of perioperative care is the key to the success of this patient, who had to take the weightage of versus continuation of the antiplatelets and reschedule of antiplatelets and all the things we have to do. Thank you so much, sir. And these are my references. Thank you so much.
Thank you, Satish Kumar, sir, for that exhaustive presentation and using those latest 2024 guidelines. And as rightly you have said that we have to balance the risk of thrombosis with the risk of bleeding whenever a patient is taken up for non-cardiac surgery. And that's the thing that the anesthesiologist also has to look into. So we'll go for the questions and the... Sir, Meenakshi sir, can we go for the questions?
In the chat box, there were no questions. So you can have your wind-up remarks, sir.
No questions in the chat?
No questions in the chat box.
Yeah, so that was a good discussion today that we had with Vignesh talking about the physiology of the coronary circulation, where he mentioned about the autoregulation and the role of adenosine as a local metabolite for causing vasodilatation, and especially in the ischemic cardiac tissue, adenosine is known to cause vasodilatation. And especially he mentioned about the factors affecting the diastolic arterial pressure and the LVEDP. And it was followed by a good discussion on the coronary stents, especially the older bare metal stents, followed by the evolution of drug-eluting stents with the first generation stents, which used sirolimus and paclitaxel, followed by the next generation, which used everolimus and biolimus drugs, and then followed by the latest bioreabsorbable stents. So again, Rajasekaran sir gave us a wide perspective on how these stents are being used, and why bare metal stent and why the drug-eluting stents are being used to prevent the drug-eluting stents prevent the instant restenosis. And then we had, for following this, we had how the anesthetic management for a patient, which is very common nowadays because we find patients coming because of the huge incidence of coronary artery disease. Every other day we are faced with a patient with a coronary stent. So a very exhaustive presentation by Sateesh sir on the what all the anesthesiologists should look into. So it was great insights provided by all the three speakers. I would like to thank all the three speakers for that exhaustive presentation. Over to Meenakshi sir.
Sir, thank you, sir. It is a very good discussion by all the three. And for formal vote of thanks, I request the Treasurer, ISA, Puthukkottai City Branch, Dr. Hema.
Good evening, everyone. I thank you all for your participation in today's topic, coronary stents and implication, the sixth episode in the second edition of ISA Puthukkottai Budhan. My sincere gratitude to our academic chairman, Dr. A.L.M. sir, for skillfully guiding us in ISA Puthukkottai and encouraging us in the participation. I thank Dr. Vignesh, postgraduate Andhra Medical College, Visakhapatnam, on his topic on physiology on coronary circulation. That was a very seamless presentation, Dr. Vignesh. Thank you. I thank Dr. Rajasekaran sir, retired professor, retired HOD, Department of Anesthesiology, sir, on giving us a detailed and simplified, basic and elaborate presentation about coronary stents, sir. Sir, both your photographs are very beautiful, sir. I thank Dr. Satish Kumar sir, Assistant Professor, Department of Anesthesiology, Andhra Medical College, on his topic on anesthetic management and coronary stents. So that was very detailed and elaborate presentation. Thank you, sir. I thank our moderator, Dr. Vijish Venugopal sir, for skillfully guiding us through today's coronary art and its implication topic. I thank you, sir. Thank you, Clarinet, for your cooperation. I thank all the consultants, faculty, postgraduates on your enormous participation and continuous support. Your presence and attention have contributed greatly to the success of this event. Thank you all. Thank you for the wonderful evening. Thank you. Thank you, everyone.
Thank you, please. Anything, sir?
Thank you all.
I now hand over the session to Clarinet for the concluding remarks. Clarinet.
Hello.
Yeah, is there Clarinet?
Yes, sir.
Yeah, you can give that for concluding remarks.
Sir, can you repeat? Hello. Hello, sir. Hello.
Yes, it is audible.
Sir, about the question for till now, we have not received any delegate query.
That we have, there's a scene that there is no clarification or questions. Now we have to wind up the session, so you please give your concluding remarks.
Okay. Thank you so much, sir. Thank you so much, everyone, for giving us the opportunity to host this session. So with this, we are concluding today's session over here and looking forward to host you again. Thank you so much, sir.
Thank you, sir. We will leave. Thank you. Thank you all.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, sir.
Thank you. Thank you.
Thank you, sir.